Good evening. My name is Dr. David Doman, and welcome to another edition of Housecall. What's new with the diagnosis and treatment of breast cancer? Find out more right now. My first guest is Dr. Rend Al-Khalili. Rend, welcome to Housecall.
Thank you so much, Dave, for having me.
Tell our viewers briefly about your professional background.
Sure. So I am a breast imaging radiologist at Georgetown University Hospital. I did my medical school where I grew up back home in Iraq at University of Baghdad. And after relocating to the States, I did my diagnostic radiology residency at UMDNJ, that's now called Rutgers University in New Jersey. And I did 1 year of breast imaging and intervention at Columbia University Hospital. And after relocating to this area, I practiced in a local private practice in Washington, D.C. area. But because of my passion for academics, I transitioned to academia in 2017, and I've been at Georgetown since then.
Very nice. So tell our viewers briefly the topic at hand, breast cancer. How common is it in the USA?
So breast cancer is the most common cancer in American women, second to, or with the exception of skin cancer. It is the most common, second most common cause of cancer death, second to lung cancer. So we all know that 1 in 8 women will be diagnosed with breast cancer in the United States in her lifetime. And it is actually expected that in 2023, over 300,000 women will be diagnosed with breast cancer, and over 43,000 women will die from it. So sadly, the average is every 2 minutes, there is a woman who will be diagnosed with cancer, and every 13 minutes, someone will die from it.
And you certainly are at the nexus of all this, because I would imagine early detection, early diagnosis maximizes survival.
Absolutely. So we see patients from different backgrounds, and what we recommend is that we start the screening program at age 40 and do it annually. The woman can continue to do it as long as she is healthy. And these are the recommendations by the American College of Radiology and the Society of Breast Imaging. And the reason why we offer it every year is because we're looking for small tumors or early cancers before they had spread to lymph nodes, so that we can offer less aggressive treatments. Now, there are different societies and organizations that might disagree. They would say that we have to start at 45 or start at 50, which might be confusing for patients. And they also say we can do it every 2 years instead of every year. But they all agree 100% that starting at age 40 will save most lives and will decrease the mortality rate by about 30 to 40%. And most of our patients say, well, I don't really need to screen because, not most, but a lot of patients will say that I don't need to screen because I don't have family history for breast cancer. But we want patients to know that most patients with breast cancer actually do not have history or family history of breast cancer.
So if somebody is coming in for a routine mammogram, talk us through the process. They arrive in your center, and then what happens?
So the average risk woman who is asymptomatic will arrive at the center, will be eligible for a screening mammogram. Our technologists will review a list of questionnaires asking about her background and about some risk factors, and also double checking if they have symptoms or not. So then they would undergo the screening mammography, which entails taking a picture or a total of 4 pictures. And right now we are offering a newer technologies that's a 3D mammography. With the 3D mammography, the X-ray tube rotates in an arc and takes multiple low-dose images that get reconstructed into very thin slices. So this allows the radiologist to scroll through these slices just like a CAT scan and analyze each slice individually, and will allow us to know if this is a true cancer within this slice or is it overlapping tissue. And we always explain it to patient that when it's more like an analogy. So compared to 2D mammography, 3D mammogram is more like a book that is, you're seeing the front cover, you're seeing the back cover, but you can actually flip through the pages and analyze each page or read each page individually, versus a 2D mammography will only look at the front page and the back page, and with all the pages overlapping. So we do a total of 4 images, looking at it from top to bottom and looking at it sideways. And then because of the 3D software, we're going to end up with a lot of images. For example, I think it takes up to 300 images, compared to 2D mammography takes only a total of 4 images. So you can see there's a ton more information with the 3D mammography. After doing the mammogram, the woman will leave the center, and then the images will be submitted to a radiologist who will analyze the images. And if the mammogram looks completely normal, then the woman will get a letter in the mail saying that everything is fine. Now, if the radiologist is reading it and sees a specific finding, then someone will from the staff will give her a call and will ask the patient to come back for additional pictures. Now, when the patient comes back, it's going to be called a diagnostic mammogram, and we will obtain additional pictures that are focused on that abnormality. Most of the times, the abnormality is going to be benign, and a lot of times it's going to be due to overlapping tissue. But if the abnormality is still there and it's looking concerning, then the patient will have a targeted ultrasound. After the targeted ultrasound, we'll decide if it needs a biopsy, or if this needs to, if it's something benign, that the patient can come back a year later for her annual mammogram.
So let's go on to what you just left off at. If somebody has an ultrasound or a follow-up targeted mammogram, and it appears that there is a lump in the breast, and it's now been recommended they come in for a guided biopsy. Talk our viewers through that step by step. They return to your center, they've checked in, and now discuss with the viewers, as you do with your patients every day, what's involved with the biopsy.
Right. So we reassure our patients that it is an hour procedure. They don't need to have someone with them to drive them. It's going to be under local numbing. We ask patients if they are on blood thinners to withhold the blood thinners for a couple of days prior to the procedure, and we double check if they have any allergies that we need to know about. We tell our patients that it depends on the image. So if the finding is found on mammography, then the biopsy is going to be done under mammography guidance. And if the finding is found on ultrasound, then it's going to be under ultrasound guidance. We clean the skin very well, and we give local numbing, and everything is done in real time. So we use a special needle that's going to go and take multiple samples from the lesion. And at the end of the biopsy, we leave a very small titanium marker that's going to sit in the biopsy site. And the purpose of this marker is to mark the area in case we need to come back and find it. This marker is going to show up on next year's mammogram if the finding is benign. Now, if the finding is not and needs surgical excision, then this marker is going to help us find that area and come back to it, and we can localize it for the surgeon if they need.
Does the procedure hurt? That's what the viewers are wondering.
So because we give local numbing, most of the procedures are not painful at all. The first pinch from giving the numbing, and I always tell patients, is very similar to when you're having a tooth filling or the dentist office. You feel the very first pinch from the numbing, but then everything can be 100% pain-free. And a lot of patients, cannot believe that the procedure is over. Because local numbing works like magic. So we do give about 8 to 10 cc's of lidocaine.
And how rapid is the recovery after the procedure is completed?
So the local numbing sticks around for about 2 hours. After the local numbing wears off, we tell patients that they could use Tylenol for pain. But most patients actually do not take any medicine for pain because it's not going to be actual soreness. It's mostly feeling of tenderness if they touch the area. We recommend that they use ice packing on and off until midnight. And if the patient experiences bleeding, then they would have to hold pressure. And the pressure, actually, we do it with our hands after the procedure is done, but we do notify the patient and alert them that if it happens at home, then we would ask them to hold pressure for a few minutes. And if it doesn't stop, then we recommend that they go to urgent care. However, this is very unlikely to happen, maybe for patients who are on blood thinners. And most patients have very, very minimal complications. The two complications that we discuss is the bleeding, which is very minimal and unlikely to happen, as well as infection that is very close to zero, but it's not 0%. That's why we always talk about it, but we almost never see infection cases anymore.
We've got 1 minute before the break. Important topic that you hear is some women have dense breast tissue. How common and significant is that finding? And you have 1 minute.
Yes. So to explain it very quickly, the breast is composed of fibrous tissue and glandular tissue where milk is produced and fat. And when women are told they have dense breasts, basically it means they have more glandular tissue than they have fat in the breast. And this glandular tissue appears white in color on the mammogram. So it's very important because the denser the breast, the harder it is for the radiologist to find tumors within the breast. And we sort of explain it to patients like trying to find a very small snowball in the middle of a snowstorm. So it really decreases the mammographic sensitivity. And we do recommend that patients would talk to their doctors about it after they are notified, so they can discuss if there are any possibility of having a second test to help with identifying tumors in addition to screening mammography.
Excellent. Rend, thank you so much for the information. If our viewers have any questions, where can they reach you at the Georgetown Center?
So I work at Lombardi Cancer Center at the ground floor where Betty Lou Orsman Cancer Center is. And I'd be happy to answer any questions that viewers have.
Thank you so much for joining us on Housecall.
Thank you so much for having me. It's a pleasure.
We're going to pause briefly for a public service announcement. When we return, I'll be interviewing Dr. Ian Greenwalt, a noted Georgetown breast surgeon. We'll be right back.
We're all just trying to keep things running for those who rely on us.
Ready!
That's why we don't have time to be sick with the flu. And especially this year, no one has time to get sick. Get a flu shot for yourself and those around you too.
We're back. Our topic tonight is breast cancer. And my next guest will be Dr. Ian Greenwalt, a noted breast cancer surgeon at MedStar Georgetown Medical Center. Ian, welcome to Housecall.
Dave, thanks to you and your team for having me.
My pleasure. So briefly tell our viewers about your professional background.
Sure. So as you mentioned, I'm a breast surgical oncologist at MedStar Georgetown. I did my medical school at Drexel University College of Medicine in Philadelphia, and then went back home to Cleveland for some general surgery training at Case Western Reserve, and then came out here and did my advanced surgical training in breast surgical oncology at Georgetown and at Washington Hospital Center. And I've been lucky enough to stick around and continue my career here.
Very nice. Now, of course, we were discussing with Rend earlier, doing routine screening mammography and then doing targeted biopsies if something is found. But let's take a step back and discuss what should our viewers look for when they're doing monthly breast exam, for example, in the shower. Is there anything they should look for that may give them a red light that they need to get evaluated?
Yeah, it's a great question. It's something that I talk to my patients about all the time, and I'm definitely an advocate of breast self exams and just being aware of your own anatomy. But the things that would pop up on my radar that I would recommend someone be seen for would be things like new masses or new lumps in the breast, if there's any changes to the nipple or the areola, particularly if they're pulling back into the breast. And any changes to the skin overlying the breast, such as redness or bruising, and any discomfort or swelling underneath the arms. But I always talk to my patients about, context is important. And if this is something that comes up and then within a week or two is gone, for the most part, that's nothing to be too alarmed about. But these things that persist and stay really, really should be evaluated.
Tell our viewers what is something called peau d'orange.
Yeah, peau d'orange is a finding. It's a physical exam finding, specifically regarding the overlying skin on the breast, and it's a French term, basically describing that the skin of the breast almost looks like the peel of an orange. And what happens there in the context of breast disease is if there's inflammation or potentially an underlying breast cancer, then it can lead to swelling in the skin, sometimes retraction of some of the ligaments in the breast, which leads to a little bit of pitting in the skin. And in those situations, sometimes it truly is a benign process due to maybe inflammation or infection, but we want to make sure that it's not being caused by perhaps an underlying cancer.
So a biopsy is done of a lump, and it comes back breast cancer. What is the next step when they're referred to you?
So, yeah, oftentimes it's a very common scenario if someone is unfortunately diagnosed with breast cancer that their first meeting is with a breast surgeon. And oftentimes that's because we'll act almost like a quarterback in the sense of starting the process of treatment. It doesn't necessarily mean you go right to surgery, but we help guide the patient through the process. And so after a biopsy has been done, we'll have a meeting where we review the diagnosis and then discuss with the patient kind of the multidisciplinary approach to breast cancer management. And what that means is kind of a team approach where different doctors, whether they're myself, a surgeon, a medical oncologist, radiation oncologist, we all get together to discuss their case and figure out what's the next most appropriate step in treatment, whether that's surgery or medical therapy. But yeah, that's usually the first step. There is a thorough discussion about the diagnosis and the next most appropriate steps.
So do you do any sort of x-rays to see if the cancer is limited to the breast or is already spread beyond that field?
Yeah, it's an important thing to understand when someone's been diagnosed with breast cancer, the biology of the disease, so how it's going to behave, but then also the extent of the disease. Is the disease just within the breast, or are we concerned that it's in other parts of the body, like the lymph nodes underneath the arms or elsewhere? So there are some situations where if we're worried about a more advanced breast cancer, that we'll need some additional imaging, which is where Dr. Al-Khalili and her partners are incredibly helpful for us in terms of figuring out other areas that can be affected in the breast or underneath the arm, or sometimes doing other scans in the body to figure out if there are places where the disease has begun to affect other parts of the body.
If your preliminary assessment is that it's limited to the breast and it's one malignant nodule, is it your sense that when they have the excisional biopsy, that the lump is removed, that is the complete treatment?
It really depends on the disease itself, because the cornerstones of treating most breast cancers is a combination of therapies. We know historically that patients typically do better when breast cancer is approached from multiple angles. So surgery is an important part in terms of clearing the disease locally from the breast, but also surgery in and of itself is somewhat incomplete therapy. We often need help from our radiation oncology colleagues and our medical oncology colleagues to get patients the best outcomes, particularly the longest survival and the lowest chance of cancer recurrence or cancer coming back.
So when do you choose radiation as your adjunctive therapy, and when do you choose a sort of chemotherapy?
So with radiation therapy, it's often used in conjunction with the most common operation that we do, which is called a lumpectomy or partial mastectomy. And that's when the tumor itself is removed, but the remaining healthy portions of the breast are preserved. Radiation is used in that situation because as surgeons, we'll remove everything that we can see and feel. However, there can be microscopic disease that remains, and we need assistance there. And that's typically where radiation comes in. It destroys any remaining microscopic disease while preserving surrounding healthy breast tissue. In regards to chemotherapy, that has much to do with the biology of the cancer. With more aggressive cancers that many reviewers may have heard of, such as triple negative breast cancers or these others called HER2 positive, typically those cancers respond very well to chemotherapies, but oftentimes we will need to complement that with surgery or radiation as well.
Now, of course, for so many years, chemotherapy was relatively toxic drugs to kill any bad cells out there. But now there's all this elegant new options in terms of hormonal therapy, immune therapy. When do you choose which option for a particular patient, or do you choose more than one of these options?
Yeah, I mean, it's a huge credit to our medical oncology colleagues and the work that they've done and the research that supported their work, in that we've become much more personalized and much more individualized in terms of figuring out what type of medical therapies to offer patients. And so you're correct. There are some patients who really need everything thrown at their cancer in terms of chemotherapy, hormonal therapy, endocrine therapy. And immunotherapy. A lot of this is driven by the receptors on the cancer. So whether they are hormonally driven, like estrogen and progesterone, or they're not in these negative cancers. But the main determining factors there have to do with the biology of those tumor receptors and tumor markers. And the medical oncologist, their goal is to effectively treat the cancer, but obviously minimize side effects and make sure their treatments are as safe as possible for the patients.
So we're at a point now where you truly can individualize therapy based on a particular patient and their cancer.
Yeah, and we're trying to push that even further too, in terms of not just based upon cancer biology, but also someone's individual genetics, and we will assess their genes to figure out why a cancer perhaps happened, but then also more importantly assess the genetics of the cancer and the tumor to figure out are we putting patients on the correct medications, because we want to make sure that we're giving them the most benefit possible.
An interesting trend you're hearing more and more in cancer management, including breast cancer, is that patients may not be cured of the cancer, but because of the therapy they're on, they coexist with it, kind of like having hypertension. Is that a trend that you're seeing as well?
Well, in most situations, and again, this is a credit to kind of the multidisciplinary approach, and particularly how much better we've got in the breast radiology realm of picking up cancers early. We often pick up cancers in very early stages, and so we are able to offer patients cures. However, there are situations where that's not possible. And it does become this state of coexistence where medical oncologists have developed therapies that allow patients to tolerate these therapies, have a good quality of life, and live a long time with a metastatic disease that in the past would not have allowed them to survive very long.
Ian, we've got 1 minute left. If our viewers have any questions, how can they reach you?
Yeah, of course. I work at MedStar Georgetown, and also see patients out in Maryland at our Chevy Chase location. But I'm happy to see patients regardless of if it's for more information or for an acute process. but at the Betty Lou Orsman Center down at Georgetown, and then also reaching out to our facilities in Chevy Chase. We can accommodate whoever needs us.
Well, thank you so much for joining us on House Call.
Thank you so much for having me.
My pleasure. My thanks to Dr. Ian Greenwalt for an excellent interview. My thanks for my team at the studio, and my thanks to you, the viewer, for joining us this evening. Tell us how we're doing. You can reach me at my website located at the bottom of the screen. As for our next show, we'll be interviewing the Georgetown Brain Tumor Center, a collaborative effort to deal with brain cancer and other tumors. It's going to be a fascinating show. See you then next time for another edition of House Call. Good evening.